Today, I'm going to talk about primary immunodeficiency diseases, which are underdiagnosed at any age. Before we discuss immune deficiency, let us start by considering a healthy immune system. The immune system is composed of lymphoid tissue, blood cells, proteins in the blood, the respiratory tract, and even physical barriers like skin, all designed to protect the body from harmful substances. Cells in the blood that participate in the immune response include the white blood cells, such as T and B lymphocytes, shown on the right, and granulocytes and monocytes, shown on the left. When the body's immune system encounters a harmful pathogen, such as a virus, bacteria, or a parasite, an immune response is initiated. It can be a specific cellular response, such as a B cell making an antibody to the bacteria, or a more generic response, such as the release of inflammatory cytokines. These two different mechanisms are called innate and adaptive immune responses. The innate immune response is nonspecific, inborn, requiring no training or previous exposure to the pathogen. The complement cascade involving the alternate pathway, and cells such as macrophages and neutrophils participate in this type of mechanism. In contrast, the adaptive immune response is an acquired reaction, requiring previous exposure or education on whom to mount a response against. T cell and B cell mediated immunity are adaptive immune responses. Immunodeficiency is a state in which the immune system's ability to fight pathogens is compromised or absent. If someone has a defect in their B lymphocytes, their ability to make antibodies is impaired, resulting in repeated bacterial infections rather than effective clearance of the bacteria. Immunodeficiencies can be grouped into two major classes: those that are inborn and caused by a genetic mutation, called primary immunodeficiencies, versus those patients that were born with normal immune systems, but immune deficiency develops later due to factors such as malnutrition, chemotherapy, leukemia, etc. My talk today is going to focus on the primary immunodeficiency diseases. PID can have childhood or adult onset. There are quite a variety of conditions, with more than 185 disease states associated with PID. The incidence ranges from 1 in 500 to 1 in 1,200 people in the United States, with many being undiagnosed. Typical clinical presentation can be described as SPUR, severe, persistent, unusual, and/or recurrent infections. And with the genetic nature of the disease, it is often present in families. Although more than 25% of PID are pediatric, PID is not just a childhood disease. A 1995 national survey of primary immunodeficiencies found that more than 40% of PID patients were not diagnosed until adulthood, despite the fact that many had a history of serious or chronic health conditions such as sinusitis, bronchitis, and pneumonia. In 2014, the International Union of Immunological Sciences classified the more than 185 primary immunodeficiencies into 9 different categories. For example, predominantly antibody deficiencies, PADs, are the most common PID. Combined immunodeficiencies include the most severe diseases, such as SCID, or severe combined immunodeficiency disease. The combined immunodeficiencies with syndromes are the diseases for which the genetic defect is known and has a wide range of effects. The newest category is at the bottom, phenocopies of PID, which represents inherited immunodeficiencies that are not due to germline mutations but arise from acquired mechanisms. This pie chart depicts the distribution of the PIDs among 8 different categories. Predominantly antibody disorders are more than 50% of all PIDs. Which brings us back to the main problem. PIDs are more common than previously estimated. The underlying cause of recurrent infections are often not investigated. Diagnosis can be delayed on an average of up to 5 years. Diagnosis is often only after 3 significant hospital visits. PID in most cases is easy and cheap to diagnose. Thus, more education and awareness is needed. There are many consequences to delayed diagnosis of PID. There are severe and recurrent infections, frequent hospital visits, some of them involving intensive care. There's long-term morbidity or disability, reduced tissue function. There can be absence from work and/or school, which impacts school life as well as your career. And there's an impact on the healthcare resources. The Jeffrey Modell Foundation has developed posters of warning signs for PID. This poster covers 10 warning signs for both children and adults, including frequent ear infections, ineffective antibiotics, frequent pneumonia, or failure to thrive. For adults, the warning signs are similar, but also include repeated sinus infections, chronic diarrhea, as well as recurrent viral infections. Again, PID is not just a disease of children. The impact on health depends on the extent and severity of the PID. If both cells and antibodies are defective, the disease can be severe and life-threatening. If it is a partial defect, the health impact is less noticeable and can be harder to diagnose or recognize. As mentioned in the previous slide, severe combined immunodeficiency is the most severe form of PID. Individuals with SCID have no T cells and no antibodies. It is a rare condition, 1 in 100,000 births, with X-SCID the most common type and found in boys. Recurrent infections develop in infants, causing failure to thrive. This is considered a pediatric emergency, and 17 states screen all newborns for SCID. Perhaps some of you remember the bubble boy, David Vedder, who was born in 1971 with SCID in Houston, Texas. His infant older brother died of the same thing, so his parents arranged for a germ-free delivery. David lived in a sterile plastic bubble until the age of 12. He was given an imperfect match bone marrow transfusion at age 12 from his sister and became sick. He lived for 15 days outside of the bubble to get treatment, and he died from Burkitt's lymphoma due to a latent EBV infection from his sister in 1984, 4 months after his transfusion. The genetic defect in his cells that caused his SCID was later identified in 1993 to be in the interleukin-2 receptor. Testing for primary immunodeficiency usually occurs in stages, with more general tests done up front, such as complete blood cell counts and total immunoglobulin assays, followed by more specific and specialized testing, such as IgG subclass, vaccine response, and complement assays. For today, we will focus on predominantly antibody deficiencies and complement deficiencies. Let us start with the PIDs. You will recall that B lymphocytes mature into activated plasma cells. Plasma cells secrete antibodies, 1 type per plasma cell. A person needs a wide variety of plasma cells and antibodies to mount successful immune responses. There are 5 types of antibodies. IgE, the least common, is involved in the allergic response. IgD activates basophils and mast cells in innate immunity. IgA is present in mucosal areas and in secretions. IgM is involved in the primary or first immune response, and IgG is the most prevalent, constituting 75 to 80% of all antibodies and the majority of antibody-mediated immunity. IgG is involved in the secondary or memory response, and there are 4 subclasses of IgG that we will discuss later. As shown earlier, diagnosing PID involves testing in stages. The specific order or algorithm often depends on the type and experience of the clinician. If someone presents with recurrent bacterial infections, such as sinusitis, otitis, or pneumonia, one should consider antibody deficiencies. Determining total immunoglobulin levels is a very important step in PID testing. Dysgammaglobulinemia is a hallmark of primary antibody deficiency and results in low levels of a single or multiple antibody class. Selective IgA deficiency is one of the most common PIDs. Studies have indicated 1 in 500 Caucasians have selective IgA deficiency. Many people have relatively mild illnesses and may never discover IgA deficiency. The IgG antibodies can be subdivided into 4 different subclasses: IgG 1, 2, 3, and 4. PID may occur even with normal IgG levels as a result of IgG subclass deficiency. The patient may be asymptomatic, have recurrent infections, or have poor response to specific antigens due to a subclass deficiency. This table shows the prevalence of the different subclasses. IgG 1 and 2 are the most abundant in the serum. IgG 2 is usually associated with immune response to polysaccharides, while IgG 1 and 3 are more associated with responses to proteins, such as from bacteria, virus, or other immunogens. Another standard test for diagnosing PID is vaccine response assays. They measure the ability of the immune system to respond to pathogens and produce specific antibodies to the antigen by using common vaccines. Deficiencies can occur with normal IgG and IgG subclass levels. A poor response indicates immunodeficiency. Various tests used include using protein-based vaccines such as tetanus toxoid or VZV, a protein polysaccharide conjugate like HIB, or polysaccharide or carbohydrate-based vaccines such as Typhi. Recall from the previous slide that IgG2 responds well to polysaccharides, while IgG1 and IgG3 respond to protein antigens. To help put all of this information together, the next 3 slides are examples of cases of PID. In this case study number 1, a 48-year-old man was admitted for weight loss associated with intermittent diarrhea. He had a history of pneumonia as a child and once as a young man. At age 33, he was diagnosed with chronic sinusitis, persistent headaches, and he was underweight. The lab tests included total serum IgG and M, which were normal, but his IgA was very low. Subclass testing, IgG 1 and 3 were very low, IgG 2 was normal, and IgG 4 was high. His vaccine responses to T-tox and diphtheria had a poor response, and Pneumovax was a normal response. His diagnosis was IgA and IgG subclass deficiencies with chronic sinusitis. The next case is a 35-year-old woman. She had a history of recurrent respiratory tract infections, yeast infections, and urinary tract infections. No underlying cause was found, and the symptoms were thought to be possibly psychosomatic, and she was treated for depression. She was finally referred to a hospital immunology department. Lab tests included total serum IgG, IgM, and IgA, which were all normal. Subclass testing was done. The IgG1 was normal, IgG2 was normal, and IgG4 was normal. However, IgG3 was greatly reduced. Her diagnosis? She had an IgG subclass deficiency, and her recurrent infections were reduced with subsequent IV immunoglobulin therapy. This last case is a pediatric patient. At 3 months old, the baby developed otitis media and an upper respiratory tract infection. At both 5 months and 11 months, the Haemophilus influenza pneumonia was contracted. At 16 months, a Candida infection. And at 18 months, the baby was diagnosed as failure to thrive. The infant was fully immunized with a round of vaccines. The lab tests included serum IgG, A, and M, with very low IgG and M found, and no detectable IgA. For the vaccine responses, no IgG antibodies were detected. The diagnosis was X-linked agammaglobulinemia, or XLA, which was confirmed by the detection of the mutated BTK gene. So we have described predominantly antibody deficiencies and seen 3 examples of patients with PID due to dysgammaglobulinemia and poor vaccine responses. Now we are going to look at